Kendrick's webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming.
I can't hear. I'm not sure if anyone can hear me. I don't have any audio. One moment as I try to handle some technical difficulties as I cannot hear anything. Okay, I've actually joined through my cell phone, so hopefully I can get audio here. I've joined.
Okay.
If that's not a problem for you.
Yeah, okay. I can do that. Tell me your background. I can hear you that you're meeting.
Sure, I can hear you. But I can't hear you now, though. I don't have any audio on this. For some reason, I'm not getting your audio signal. Yeah, I would have to bring a new setup up because I'm not hearing you.
Hello, can you hear me? No. You can hear me? You can hear me now? You can hear me now, right? Mm, I did set up right. He's connected. I don't know why it is not. Maybe it came out. Hello, hello, hello. Mm. Ladies and gentlemen, sorry, we are having a lot of problems today, technical problems. So we may have to cancel this today and we may have to reschedule it again. So we are having a lot of problems, audio problems. I always ask the doctors to come a little bit 15, 20 minutes earlier because this is a challenge. It's not when you're doing a live, you have to get everything, all of them has to be cleaned up. It is a frustrating. Um, we're not there yet. Silicon Valley claims big time, but it's not there yet. It does not understand the natural language. It is not that as you think. They're AI and all these things. Just they talk big. It's just they're good salespeople. We have to really understand the human problem and fix it. If I talk in natural language, my microphone is not working. You should be able to go and fix it. It's not doing it. So that doesn't mean. So that is a problem right there. I cannot hear him. He cannot hear me.
I can hear you.
You can hear
I can
me?
hear you.
I can hear you now.
I can hear
Oh,
you.
good. Now I can hear you.
Yes, we're good.
God. So we're going to continue. We're not going to cancel the thing. We're going to record it and I cut down the previous portions. Dr. Kendrick, yeah. Can you hear me clear?
I can hear you clearly.
Okay, that's why doctors are a little bit of a godly complex, sir. I know you, I met you. I tell you, you need to have a technology, you have to be humble. There
But
is no other,
it's
even
it's not
the,
you.
huh?
It's actually my computer. So I could log on, and that probably was logging on once I went to. You had another um, streaming website or URL. When I used that one, I got in. The one that you sent me that had a lot of links in it, that's not the one I guess I was supposed to log into.
Can you
So
do
I
the
got
one more
in.
thing? One more thing. You go to the restream. There is a gear set in there. Click the echo. When you click on the gear setting in the gear settings, suppression, echo suppression, and noise suppression. Both both turn it off. In the bottom, you see a gear. Then go to audio on the left side and gear suppression, audio
Testing.
suppression, and the
Uh,
noise suppression. Turn it off.
I'm trying to do echo. Oh, here it is. Hold a second. This is master volume. Can you hear me now?
I can hear you clearly.
See, that's what's happening. It is. Let me go to another one. Testing.
Noise suppression you can keep it, but echo suppression just turn it off.
Can you hear me now?
Yeah, I can hear you clearly.
Okay, hold on one
Don't change anything.
second.
Now it's good.
Okay.
Thank you, Dr. Kendi. So let me start from the program all the way. Let me start this program. I'm going to play from the beginning itself, okay, if you don't mind, okay? So let us start that is a live, but I'm going to do that in the previous version. I will cut it out. So I'm going to live. Just to stay on the background. Don't touch any buttons. You're going to be in the
No.
background, okay?
So I'm going to start this whole thing a little bit delayed. So still. Albert Einstein, but I feel that something's wrong. Yes, it is. No, I ain't no Albert Einstein. I just feel that something's wrong.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming.
Webcast. This is Ramana Anam Raju. That is the Dr. Edwin Kendricks. Edwin Kendricks is let me both of us to bring it now because of all the problems we have. So just a minute. Okay. This is I'm going to turn it off. I'm going to yeah. That is EKM. I got to remove this one. I don't know what is this. Hide it. Okay. Okay. So this is Dr. Edwin Kendricks. Tell us, Dr. Kendricks, with all the technical problems we have, tell us a little bit about your background. You're a vascular surgeon. You came from my hometown, Atlanta, Georgia. You went to Morehouse Medical School. So we have some common friends, maybe. I know Dr. John Poindexter very well. Then Doctor, if you remember or not, Dr. John Poindexter is a vascular surgeon in Atlanta. His wife is 11, and they started in the beginning days, 1990s. They started a what do you call a HMO, PPO. It's kind of a vascular surgery group, specialty group. I was part of it. Gary Matthews was my friend. We were helping them at the time, and then I lived in Atlanta for a long time, and Atlanta is my big hometown. It is a I lived there. I actively involved with a lot of things in Atlanta Medical Association, particularly black medical doctors. I gave a I just a minute, 1 second. I'm trying to bring you to the main stage. So Atlanta is very big for me. I came from Atlanta City. My both children were born there. So tell us your journey. Where were you born? Where you came from? You don't see me, but I want to put you in the main stage and tell us about
Sure.
your background.
So I'm from Ocala, Florida. Can you hear me still?
Yeah, I can hear you.
Okay, great. Yeah, so I'm from Ocala, Florida originally, and ended up relocating, which is funny stories because I was born about 30 minutes south of Gainesville. And so I have a lot of Gators and people that have been to schools in Florida, but my father ended up relocating with the military to Georgia. And so I ended up becoming a Bulldog. And so that's where I got my start at the University of Georgia, which is a fabulous opportunity for me and a wonderful experience.
Yeah, yeah. This is okay. Now it's a little bit of making sense. So yeah, you're from Ocala, Florida. I know Ocala very well. I actually
Yes.
came down and I came to Ocala. I stayed there for 2 weeks actually
Okay.
because
Yeah.
there's a lot of horse ranches. You have a lot of horses there.
Absolutely, absolutely. Yes, a lot of agriculture there. Absolutely small town kind of feel. So I've had a wonderful opportunity to experience life in both small town, medium towns, as well as large cities as well. So I think that's been so helpful, as well as traveling around the country doing training has been very helpful in sort of not just grounding me, but allowing me a lot more flexibility, being able to also understand multiple ways we should look at topics, and so that's been great.
before I got into the real medical professional side of it, John Travolta lives in your town, right? Ocala,
That's
Florida.
right.
That's
Yes,
a big famous star. He has his own the landing strip up there in Ocala, Florida. I remember. So yeah, Ocala is famous in that one. A lot of horses. I rode a horse with my friend. It was scariest time. I didn't like it. So, Dr. Wakala, you're not that far from Tampa. So let me ask you, you're close to Gainesville, right? Sorry, Tampa is far. Gainesville is very close
that's
to it.
right. That's
So you
right.
went from all the way from there to Maryland. You did a vascular fellowship in Maryland. You went to the Morehouse Medical School, right? That's what you did a internal medicine residency there, right?
I'm sorry. You said what now? That I relocated to Maryland,
No,
Vascular
the
Surgery
first time
Fellowship.
you went to Atlanta, did the internal medicine first, right?
So medical school was in Atlanta at Morehouse.
Okay,
Then I did residency training at UT Memphis as well as Morehouse.
okay.
Business school was at Emory, and then I went back into fellowship for vascular surgery, and then began practice. And
What
there
were
was a
you doing?
healthcare tech company. There was a healthcare care. My first healthcare tech company actually was intermixed between general surgery and actually vascular surgery. So I did business school and ran a healthcare tech company for about 5 years before that.
I used to have a diagnostic center next to the actually Crawford Log Center. At that time, it used to be called Crawford Long Center.
That's
So
right.
I'm
Yes.
I know all the vascular surgeons in Atlanta. I'm very quite familiar with Atlanta. So they went to the Maryland. You went to Baltimore, Maryland, and then how did you get into? You were doing a vascular fellowship in Maryland, right?
Yes.
Then after that, you got into John Hopkins biomedical engineering. Tell me that journey. Why did you got interested in the biomedical engineering side? You're coming in my field. So tell us a little bit about that.
Sure, sure. So, I would say the story goes back to probably my first year of residency. And it was during my first year of residency that I realized that I had a interest in designing devices. I would see devices that we were using as a surgeon, surgical resident, and I really became intrigued about how to make things better. And so at that time, we had actually a biomedical engineering program at UT Memphis. And I was really intrigued about considering should I do it? And given the schedule that we were working at that time, well over 100 hours a week, I realized it wasn't going to be an opportunity to do it. So what I ended up doing was decided to just buy books, figuring out how to log in and develop devices myself. So that led me to actually encounter with my first engineer was actually from Georgia Tech. And we started working on our first biomedical device, I would say, at least the process of that during my residency training. And so that's really where it started.
What kind of a device is that?
Well, that one was going to be a nasal gastric tube that actually was going to do some phenomenal work with. We had a lot of people with injuries. And so we're looking at various types of materials to actually make it safer, more compliant for patients, actually reduce the rates of nasal gastric tubes being removed. And so that's some of the work we were working on. But one of the benefits of that is sort of me coming to where I am today is understanding that process of design, materials, costs, all those things that are embodied within engineering and device development. And so I used that as an opportunity to sort of figure out that process. We weren't successful in getting that done just because of some of the cost prohibitions that we had. But essentially, that was the launching pad for me moving from that and then getting to digital health. And so the time that right before I was enrolling in business school, started a health tech company. And we started trying to mix in both the development of, I just say software at that time. And so we looked at ways we could develop digital health solutions to improve care access and delivery, particularly as we were looking at the population of youth, where it was projected that 30% were overweight and the high obesity rate and the amount of type 2 diabetes. We looked at developing a software platform to actually assist in being able to detect and monitor people physical activity levels and nutrition. So that was back in about 2007, 2000.
I don't know. I'm pretty sure I met you with Dr. Richard Allen Williams meeting at the time, right? I came to you. You were there at the time in Los Angeles. Dr. Richard Allen Williams giving a Minority Health Institute. Were you present there?
You know, for some reason, are you hearing the echo I'm hearing about something I missed a call earlier?
What call? What call?
Are you hearing for some reason
I
I'm
can hear
hearing
you. I can hear you. Some noise coming up. Is a there's a is a basically they're all internal noises, that background noises and all those things. But I can hear you clearly. Can you hear me clearly?
I can hear you clearly, but I'm hearing like our prior conversation sort of in my background. But if you're not hearing that, that's great.
Yeah, I am not doing is echoing a little bit. Some echo problems are there. I'm trying to
Okay.
do, just it's a lot of audio is one of the biggest challenges. You have to really, that one thing is you have to work on that. A lot of people, I tell them, just let me do the noise echo cancellation. Maybe other way up. Something echo coming up from the problem is when you're doing a videos, you should use a dedicated computer. Don't use a regular computer that you use for all the other purpose, because so many background programs running that create a lot of problems. That's why I tell the doctors, when you use a small Chromebook to do the video programming, because that is the best way to solve the problems in general. So use a special one. Uh, Times use it dedicated for just video calls. Is my advice. With Silicon Valley problems. But anyway, I can hear
I'm
you
gonna
clear.
hear you
I
through all
can hear
this
you.
background noise. But yeah,
I
go
can
ahead
hear
with
you.
your question.
I can hear you clearly. But let me ask you a question. In the whether you know it or not, I'm a very good friend of Dr. Richard Allen Williams. He is a president founder of the Association of Black Cardiologists. So I attended his Minority Health Institute. Can you hear me? You can hear me, right? You cannot hear me? I don't know. You cannot hear me again. Can you hear me? Can you hear me? Don't change anything, sir. Just stick to that. Can you hear me now? Okay, you can hear me now.
Yeah,
Clear,
I
right?
could hear you. It's just I was hearing our recorded conversations from earlier. That was making it difficult for me to hear what you were asking.
Yeah, maybe that you need to stop somewhere. That app is running in the background. That's what it is.
Yeah, I have
So
all my echoes. I have
yeah,
all my echoes, echo canceling
and
speakerphone.
then close all the other windows except this window. That's probably that can solve the problems. But I can hear you clear. I can hear you
Yeah,
clear. Okay, let us talk conversation. We can't hear your conversations. Yeah, they don't come to us. So it's for you, those conversations, because that app is coming back to you probably. But
yeah.
anyway,
Essentially, just so you know, what I'm hearing now is the start of our video. So, yeah. So,
yeah,
I'm gonna try to do my best. Since you can't hear me, then I'll just try to do my best to talk over it.
I can hear you very clear. So let me ask you a question. So among the black population, there is a 30% increase in the amputation rates, three times more likely to go get amputation for the black population. I don't know whether you know it or not. I married a black woman from South Carolina, and I have two children. So it is. I go to they are from a small plantation town in Georgetown, South Carolina. So I go there, and you see a lot of these problems, amputation problems, and diabetes is a rampant, all kinds of problems there. So, so how do you solve this particularly in among the Black Americans? This amputation is a higher rate, but I'm hearing a conflicting answers from you, just a confusing little bit. So sorry to say that to you, but you Amputation Reduction Act is proposed by another black congressman. Then you did not like that reduction act. I tell us first of all, explain the what that Amputation Reduction Act of 2020. Then we can get into why you didn't like it. You can explain.
Okay, so I I'm still hearing you talk. So you asked me to explain about the amputation rate. You talked about the black population, how it's so much higher, threefold higher. And so I take it that you want me to talk a little bit about what we're seeing in the communities. Why do we think that amputation rate is higher? And then maybe
Correct.
some of those solutions that we can really look at. And to address your question, you know, talking about this is I've been at several different ways of looking at this, particularly even after fellowship and even during the care that I was providing patients all throughout residency training. And one of the things that we're seeing, we know that there's an issue of mistrust. We know that there's an issue when it comes to health literacy with being able to understand disease processes. We also know that there's a problem when it comes to health navigation. But we also understand that there's a problem when it comes to treatment. So we've seen historically where when we started comparing angioplasty or ballooning a blood vessel up to try to improve narrowing in that blood vessel versus black populations that were not treated at all, with no open social intervention. When they looked at that 2 years out, what they saw is that people that never underwent a surgical procedure and those that underwent angioplasty still ended up at the same level of amputation within 2 years. We then started adding more new technologies. We know that the technologies such as stenting, we know that bypasses actually can improve the life of the limb. But one of the concerns that we have in our community is who do we treat? We know that there's a higher failure rate with people that have what we call critical limb threatening ischemia. So let me start here. One of the issues is treatment. Who needs treatment? Who's getting treatment? And the other issue is screening. And I think both of those issues have been a problem. So let me deal with the screening first so people can understand a little bit more about what we're seeing in the marketplace. Number one, the reason that we need to do screening in peripheral arterial disease is primarily because if we can detect disease in the lower extremities early, we can end up saving a lot of lives. Because what we know is that, that arterial disease, that narrowing within that artery, is directly tied to people's higher risk for developing heart attack, developing strokes, developing kidney problems, as well as progressive arterial disease. So that's what we know that we need to do screening. We know that people that have diabetes tend to be the greatest population of people with arterial disease. And so we know that that can be 20 to 30% of all PAD populations actually have diabetes. Now, why do we need to screen? We need to screen because these people need to be on the risk factor modification medications early. We need to make sure their feet are being screened because the highest rates of amputation really tend to deal with people that have diabetes and diabetic foot infections. Those are the number one causes of amputations in communities.
I
The
showed
second,
you that there is a picture that I took it from you, and you that is I loved that picture.
yes,
You
yes,
explained very well this one, and this one is more interesting. The next one I show you. This is a little bit of explanation of this one. I loved
that's
it.
correct.
So you clearly demonstrated that the problems are the just takes. Can you explain that those three things up there on the
Absolutely. This
screen?
is actually an excellent image that talks about the healthy artery on the left side, or when we're first born, when we have blood flow moving through a vessel easily. The second one deals with red blood cells, and you can see some of those yellow circles. Those yellow circles are factors that actually increased inflammation that can result in what you see on the right side, is the disease or the narrowing of that artery, either inflammation or development of fat deposits that can create the narrowing as well. And so those yellow circles, we can consider anything like that to be inflammation, whether it be high levels of fatty cholesterols, right, that can enter the blood vessel, whether we're talking about high blood pressure and its impact on the blood vessel, right, whether we're talking about diabetes and that impact on the blood vessel. So anything that enters the blood vessel can cause problems, including people that may have autoimmune disorders, right? And you're having those circulating factors that can also cause damage as well. So ultimately, what we see is in that center, can we control people where they are with those yellow circles, either through risk factor modifications such as medication management, diet, exercise. And so we really want to keep people in that middle versus them having to end up on the far right side. And so screening is a part of that. And I think that's what we really should start. And our major focus should be on how we can screen people to provide them the risk factor modifications they need in hopes of first saving their life. Then we can actually then start looking later into saving their lives.
So, but the another black congressman suggested that Amputation Reduction Act 2020. What is your main objections for that Amputation Reduction Act? Can you explain a little bit about that? That was
Sure.
a little bit of a things we didn't understand. You supported it in the beginning, but on the other hand, you really took it out, and then you did not support it. So it was a little confusing for all of us.
Right. So what happened is we were invited to the Society of Black Vascular Surgeons, and I was actually coming on behalf of Sano Health Farm for advocacy, research, and mentoring. And I ended up having to sub for the Society of Black Vascular Surgeons as their representative wasn't able to make it, and I'm a member of the board of directors. And at the meeting, the goal of it seemed, very intriguing. It's something I've been focused on. It's something actually that we've actually written NIH grants for to try to get support for improving screening. So part of that act deals with screening early, right, to try to detect the disease. The other part deals with trying to reduce amputation. The issues and concerns that we had was number one, the screening process. As I mentioned to you, about 30% of people with PAD have diabetes. They are the population that tends to get the higher amputation rates. How this bill deals with screening has been a concern. So this bill has recommended that patients with diabetes, all patients get screened with an ankle brachial index exam. If you watch the video online that you were alluding to, what we talk about is ABI is beneficial. ABI is an ankle brachial index. And essentially what we're doing is comparing the pressure in the arm to the pressure at the ankle area. And we know that that pressure should relatively be equal, but it's going to be a little bit higher in the leg. And so we compare the pressure in the arm to the pressure in the leg. And I like to say, so if your arm pressure is 130 and your ankle pressure is 250, there's a problem there, right? And that's the problem that we tend to see in patients with diabetes.
Just let me just ask you, just clarify that. You're saying that ABI index, ABI index, is not a good standard or measurement, completely not efficient measurement of the PAD. Is that right? What you're trying to say?
What I'm saying is ABI is beneficial for people that do not have diabetes, that do not have renal disease, and in some of the elderly population. We know we
Okay.
can use ABI. However, ABI is not beneficial to people, particularly that have diabetes, kidney disease, or may have calcified vessels. Because what's happening is, with that blood pressure cuff, we need to actually test a normal vessel. That's what we're trying to test. And so if the vessel itself is calcified, it's like, I use the example, is it easier to compress a banana, right? Or is it easier to compress a steel pipe? And so if we're trying to compress a steel pipe, that's going to raise the pressure up. So that means that our ankle brachial index exam is going to be completely abnormal. We cannot rely on it.
But
That's
the
the issue.
ABI, but the ABI index you can use for mass screenings. What is your objection about ABI using as a mass screening?
The use of it as a mass screening alone means that many people with diabetes, kidney failure, renal disease, or the elderly may actually be misdiagnosed as not having it at all. So the recommendation has always been that patients with higher risk for calcified vessels need to have a toe Berkshire index. That is placing a blood pressure cuff on the toe as compare that to the arm pressure because the toes tend to be less calcified. You see, it's as if you want to do a test, you want the test to be accurate. And when we're performing the ABI exam, we're performing the ABI exam in normal blood vessels. Because those calcified vessels in diabetes tend to be so hardly calcified, the person may actually have severe arterial disease, but the registration is in the normal range. And so what we use as a normal range is usually greater than 0.9 and less than 1.3. Well, if your vessel is calcified and your ankle brachial index should really be 0.6, but because of the calcium, it's registering at 1.2. That's a patient that may not be on risk modification medication and that has been told that their ABI is normal and they don't have arterial disease. And
You're
that's
self
the issue that we're seeing.
you're self-criticizing yourself. You're saying medication management is better than a surgery there, amputation. So it is going against your own profession. They tell us that's really noble of you. But
Yes. So
do you know what I'm
it's two
saying?
issues though. It's two issues that we have to be concerned with. One is screening and one is diagnosis. And with screening, what we need to do with screening is we're supposed to be able to detect disease sooner so that we can institute therapy. That is the issue, is that we need to do that. Now, when we start talking about diagnosis, diagnosis is more so, we use other tools for diagnosis and confirming the diagnosis. Now we can intervention. So the ARC Act says two things. One is simply use ABI on all patients to test and see if they have PAD for early detection. Again, early. The problem is if you're using ABI in people with diabetes, renal failure, and the elderly, you're going to miss it. And if you miss that diagnosis and the person's not on risk modification, you miss that opportunity to improve your access. On the
You made
other
another
hand,
yeah. You made another point about the athletes, people who are runners, that claudication, that you don't need the surgery for them, you don't need stents, you can do with the medical management, unnecessary amputation for those people doing that, people who are runners. That is, you can reduce the drastically number of amputations for the people who are athletic and all those people. Tell us a little bit, one more word about that.
so I think there's a difference between, there is a difference between screening and then when we start talking about interventions. And that's what has to be clear. And it's not as clear within this ARC Act because that is a problem. When we focus on screening, we're talking about an intervention of risk factor modification. Okay. And so we want to catch, the reason for this bill should be to catch people early that have arterial disease so we can intervene in non-invasive ways. Now, when we start talking about claudication, we start talking about people with severe limb disease where they have ulcers. Now we're into the treatment mode. That's what we start using more so, but that's a different approach. That's the approach dealing with amputation. So we start talking about claudication and those kind of factors. Those are the people that tend to actually get intervention. Remember that 60% of the population do not have any symptoms at all. So that's the population that we really need to be active screening because those are the persons that we can actually reduce their risk of heart attack, stroke, and kidney disease.
Does the ultrasound help you do bivascular ultrasound, bilateral vascular ultrasound? Does it help?
Now, it can help. But again, let's talk about the screening bucket and let's talk about the diagnostic tool bucket for intervention. In the screening bucket, we know that ultrasound is not recommended as a screening tool. This is the second part of the ARC Act that we've had issues with. The concern is that if you're going to use ultrasound, we know that ultrasound is notorious for getting it wrong, or let's say getting it right, only 50% of the time, whether someone has significant arterial disease. And so the problem is, if we're going to use arterial ultrasound as a screening tool, the people with asymptomatic disease are more likely to then undergo treatment by a provider. And that's something that we need to do more research on,
Can,
because if you screen with ultrasound and then you undergo intervention, now we're talking about excessive interventions and treatments in patient population. So
you
that
know,
is the second part of use as a screening tool.
can you do this way? You do mass screenings, then segmental ultrasound, then you do imaging ultrasound, bilateral imaging ultrasound. All three you do, you can detect pathology there, or you're saying that still it can give a positive results and they result in a more amputations. I That was a little confusing to me.
Sure. So again, the difference between screening and diagnostics. You are correct when it comes to diagnostics. Diagnostics, you can use ABI with TBI, and you can use ultrasound, right? And that should be able to clarify and confirm the presence of the diagnosis and or severity, right? When we're talking about screening, we're talking about low-cost tools. And these low-cost tools are used primarily not for surgical intervention, but they're used to determine how we should monitor and manage the patient. Is the patient healthy enough where they don't require anything, or are they starting to show signs of arterial insufficiency? And that shows and suggests that they have higher rates for cardiovascular complications. So now we intervene with medication management. But the way you look at this, I'll say this, is the way you look at this is we cannot operate ourselves out of cardiovascular disease, which is the number one global killer around the world. So the goal is, how can we detect it early and then intervene to reduce healthcare costs, to reduce excessive procedures and risk of amputation.
Indians are big problem. I'm from India. It is a huge problem in India. As you know, that you're a professor in the assistant clinical professor in the University of Riverside. You must have seen a lot of Indians. But let me ask you a question. You're besides that, as a professor, kind of a professorial point of view, is there any diagnostic toolkits, like a lifestyle management, or medication management, or even other ones I see, the interprofessional communication things with the patients and the doctors? All these diagnostic toolkit would help you think, to reduce this massive problem?
Yes, again, and I like the fact that you use diagnostics, right? Because there's a difference between, again, diagnostics and screening tools. We have to have a purpose for screening tools, and that is saving people's lives, right? That is the risk factor modification. Now, when we start talking about the diagnostic bucket, now we're talking about who needs actual intervention. What we've been seeing, and this is some of the research that we just presented at the NMA just about a week ago. What
Yeah.
we found looking at atherectomy, which is essentially a roto-rooter device that cleans out plaque in an artery, right? That's a questionable
Or yeah, you
procedure.
can put a stent also, right? You can put a stent also, bypass that one, and put
You,
a.
you, could, you could do stents as well as use atherectomy tools, which is commonly done in academic centers, primarily in the community. And
You
what
can do
we
otherwise a
found
plumbing.
is,
You can do direct plumbing, plumbing the whole process, right?
yeah, what we found is that people that were undergoing this atherectomy procedure tended to be people that had claudication, right? So cramping pains, intermittent claudication, they have cramping pains when they walk, subsides when they rest, returns. Those are the highest rates of this procedure being used for the person, right?
Yeah.
Those persons have a 2 to 3% amputation rate over their lifetime, right? What we also saw is that it is used in critical limb-threatening ischemia. Those are people with tissue loss, maybe severe rest pain. what we're seeing is that those procedures have been overly used or excessively used in population. And in particular, when we start talking about Black population, minority population, these are the procedures that we're talking about coming down the pipeline where it can be excessively used because it's a substantial generator of revenue for companies.
So, if I understand you right, as an vascular surgeon, you're saying that amputations are overdone, and you need to cut down the amputation rates. We have to do the different way of diagnostics. The diagnostic tools that we have is not correctly doing the job of reducing the amputations, and then medical management is a more powerful, and then use the diagnostic tools. Is that right? That's why the act is not proposing act. The act is a law, is not a law. It is a proposal still. It is saying that it may increase the your idea of that is it may increase the amputation rates because of that law. Is that right?
I'm saying, so let me be clear. So what I'm saying is, number one, the ART Act as proposed will diagnose far less people than we should be diagnosing. So the people that have diabetes or may have renal disease or the elderly will go undiagnosed and perhaps untreated. But that's what I'm seeing in the community is that most of these patients have not been on risk factor modification medicine and they're walking around with the disease untreated. So number one, we're going to have a large amount of people, particularly diabetics, that won't be diagnosed, right? A false diagnosis, well, I should say it'll be a false negative test. So they had the disease, but it wasn't caught. So they're at risk for higher complication rates. Right? Number two is the people, if we're going to use ultrasound as a screening tool, not a diagnostic tool, but as a screening tool, the concern is that we're going to start identifying lesions that may not be significant. And then those providers, whether academic, rural, or community-based settings, will then start operating on patients. That's what we've been seeing with atherectomy, is people undergoing higher rates of procedures that don't actually need them. And so excessive procedures, undiagnosed disease leading to higher rates of complications.
So the largest national medical association, the largest Black African American Medical Doctors Association, are they supporting this act? Are they on the sidelines? What is their stand at this time as a group?
Yes, that's it. That is an ongoing discussion. And I think where we are now is what I've been learning is that not many people are aware of this act. And this is sort of caught many of us off guard. In particular, it caught my Society of Black Vascular Surgeons off guard. We just learned about it just over a year ago. Even talking to vascular surgeons at multiple institutions around the nation, and I was working with a vascular surgeon at Hopkins one time. She was unaware of this act, right? And there's a publication that came out of our communication regarding this ARC Act. And so what we're seeing is that this act does have supporters. There's industry that supports this act. There's some societies that support this act, both in vascular surgery and interventional radiology. What we don't have supporting this act is the American Heart Association or primary care providers. And so part of my job is informing people like podiatrists that may be unaware, primary care providers, National Medical Association. Now this is on their target. We're starting to look at this. We're starting to do the research that actually is starting to show what we anticipated is that it's not the atherectomy device itself that cause the higher rates of amputations, higher rates of complications. It's actually the diagnostic tools. And so we're getting back to the root cause, which is the diagnostic tools used and their impact on care access and delivery.
So final words are yours. And I want to come back and do another program next time with a clear audio, tested before. But this is very important because vascular disease is a huge problem around the world, including Indians are the biggest prone to this kind of problems. So we want to do that again, Doctor. You can do presentation next time. It is our audios are really not that clear, both sides.
Right.
So I think we need to redo and reschedule the program again. But at least we did cover basic stuff. Is that your objection, you're more, as being a vascular surgeon, you're saying the medication management, don't do rush into the screening, and it may not be suitable for everybody. So you can reduce the by and rushing to the amputations, you can always redo the things and then you check it out more. And you wanted to use a medication management and other diagnostic toolkits to reduce the amputation. That's your goal. Is it? Did I make a?
So,
Can you give me a final word on it?
yeah, just to be clear on what I'm saying is that if we're going to have a public policy that's going to affect and impact millions of patients, primarily those that are underserved, we need to make sure that we're diagnosing them accurately. And by using the ABI on everyone, we're going to miss diagnosing people. And by missing that diagnosis, those people will not be afforded that opportunity to reduce their risk of heart disease, reduce the risk of stroke and kidney failure. So that's one problem. We need to diagnose people appropriately. The second issue is we cannot make up diagnostic regimens. So, for instance, ultrasound is not used as a screening tool. And the concern is if we start doing that primarily in underserved communities, what I've seen in my family is people being diagnosed with an ultrasound and then they end up in surgery. And, having some family members that have been bilateral amputees, and that's a concern. And so we need to get we need to get the screening part right so that we can do serve its purpose of risk factor modification. The second part is just dealing with amputations. And I think that by excessive procedures, and that's what we've been seeing, excessive procedures leads to higher rates of amputation. Now, that's the antithesis of the F. And so I think from a screening standpoint, we don't want ultrasound used because we know that has a proclivity of leading to higher rates of amputation, which is the antithesis of the F.
I got it. It is a little complex situation where a little confusing and complex both together. Yes or no game is there. You want the act actually to be passed, but you don't act the way it is
No,
written that way.
we do not want that act passed because
Mhm.
the challenge that we faced was talking to the members about the need for that change. And unfortunately, they continue to submit it without those changes. And so my concern is unless something is done to ensure this act is not passed, you're talking about now negatively impacting millions of people. There's 30 million people with diabetes projected across the US. So those people could be set up to not ever be diagnosed and or treated to reduce the risk of cardiovascular complications.
Dr. Kendrick, thank you. I want to do it one more time in September, if you don't mind, because it's audio problems. We need to do it right way. It's a very important topic. It's not only for just the Black Americans, Indians. It's a huge problem, because we have narrow vessels and you have a big problem in the PAD. It's a big thing. So they need to be informed. This is a very, and even the other doctors need to know. You're a vascular surgeon, so other physicians basically think that is just do the screening and then everything is done. So they need to listen to your perspective and then understand the impact of the law, and then we need to expand in this dialogue about it. So I'm going to invite you in the September. Is it okay that with the better communication, a little bit better cameras, better communication, and good audio?
Yes, as a matter of fact, I'll have a different system too, just because I know that this system has had challenges with any type of Microsoft platform or other non-Zoom platform. So yeah, so that would be great. Don't mind
Thank you.
doing that. And hopefully, I was a little clear today with all the audio that I keep hearing. But ultimately, this is about a screening issue. Meditations we can get to, but this is a screening issue that we need to get it right.
So thank you for joining. It is truly an honor in Riverside. Is it you see Riverside? Is it a Dr. Prem Reddy? That's not is a different one, right? There is two
No,
schools in the Riverside. Dr.
yes,
Prem Reddy, or do you work for the primary Dr. Prem Reddy?
no.
Um, no,
So
the
yeah,
other
so this
one.
is University of California Riverside School of Medicine. Prim Reddy is with Prime Healthcare.
Okay. So just it is a little confusing. Okay, anyway, I will come back to you in September, and let us do it clear cut with a clear message and then good audio. I think so you can explain a lot of things. Thank you, sir. Thank you for joining, Dr. Kendrick. It's a really honor to have you in and with all the technical difficulties. Sorry we took your time, but we need to come back with a good presentation this time. Is really a message has to be cohesive. I think they understand the message in general. You're saying that the screening has to be improved, and the diagnostics and the treatment has to be, medication management has to be important, diagnostic toolkits, lifestyle management, all those things are, and then intercommunication between the patients and among the doctors is very important. You're saying, I think that is a bigger important topic. Let us talk in the September month, and I will come back to you on the schedule and the date for you.
Yeah, and thank you so much for all that you're doing to bring light to us understanding what's happening within the medical world.
Thank you, sir. Thank you all. Thank you so much. Thank you for joining. Bye. Good night, all of you.